Good afternoon, everyone, from everywhere you're watching us from and also receiving us from. We want to take this opportunity to invite you to this webinar that has been prepared and will be presented to you by our Nursing Standard Department in Kenyatta National Hospital. We all know where Nursing Standard Department is. We are located in the 6th floor of our tower block. This is a very nice presentation that will be addressing nursing documentation and reporting. One of our core activities as nursing standard is to standardize the nursing documentation and reporting and also in handing over. So this presentation has been prepared as a department, and we have our very able panel that are going to present this presentation. And just a brief introduction. My name is Elizabeth Mugi. I work in Nursing Standard. With us, we have our Chief Principal Nursing Officer, Mr. Richard Koisok, who can say hi.
Hello, team.
Wow, thank you. I'm sure after this short introduction, you'll give us an opening remark. We also have our other colleague who coordinates the CPD for nurses in KNH, who ensures that we practice with valid license. Frank, could you introduce yourself?
Yes, my name is Franklin Barine. I coordinate the CPD in nursing standards. Thank you.
Thank you so much, Frank, and to our Senior Principal Nursing Officer, who is a presenter today, just to introduce yourself briefly.
Good afternoon, everyone. Welcome to today's presentation on nursing documentation and reporting. We're glad to have you. Thank you.
Thank you so much, our panelists. I'll be the moderator for this session. I want to take this opportunity to invite our Chief Principal Nursing Officer to give us a welcoming remark and also to give us few points to take home before we do the major presentation. Welcome, Mr. Koisok.
Thank you, Elizabeth. So in my introduction, my name is Richard Koisok. Once again, the Chief Principal Nursing Officer in Nursing Standards. Nursing Standards is one of the major and very important departments in the hospital in terms of standards in nursing. And as you're told, we are situated in level 6, between 6A and 6B. And we have a number of activities, and one of them is what we are presenting today. And I want to welcome you to this presentation because one, people who have issues with CPD when they are renewing their licenses, I want to reassure you that immediately after this presentation, you will get a code. That one will be facilitated by Franklin, and you're going to gain 2 CPD points today. So if you are having like a balance of 20, then now you have a balance of 80. So kindly welcome. Listen to us. Let's discuss issues to do with documentation, and all this will be for the benefit of the patient. And just to note is you'll find documentation in our practice. We say, if not documented, it's not done. So the reason why we're here today is to make sure that things are documented. Anything you do, you document. And at the end of the day, it will be like the outcome of the patient will base at a certain high percentage on documentation, because we'll be seeing what you've done and you've documented. And also it can cushion you when we have issues to do with litigation. It can cushion you if you did your documentation very well. So with those few remarks, karibu sana, welcome. The presentation is going to take roughly 1 hour or less. Karibuni sana. I throw the ball back to our moderator, Elizabeth Mugi.
Well, thank you so much, Mr. Koisok. You are our today's host, being the CPNO Nursing Standards. Thank you also for giving the layout of where Nursing Standard is and for letting us know that this is CPD accredited presentation. And like you have said, not documented, not done. I'm sure our presenter today will emphasize on those roles and she'll give us specific examples. So on to our presenter, Madam Ruth Nyansekera, Nursing Standard Senior Principal Nursing Officer. Welcome to take us through the presentation.
Thank you again, my colleagues. This presentation is, I'm doing this on behalf of Nursing Standards. So this is our collective work. Mine is to be the mouthpiece and to speak on behalf of this team that is here. We have learning objectives because we are looking at nursing documentation and reporting. And therefore, at the end of this 1 hour, we would want to see that as the participants in this session, we are able to demonstrate an understanding of the role and the significance of documentation. So this is something you need to bear in mind. We also want to be able to discuss the principles of effective documentation. We have a number of them, and this is what we apply in our day-to-day practice. Therefore, we'll be able to discuss this at the end of this session. We also want to go through and describe various methods of documentation. And our fourth objective is to describe the various types of documentation records, as we shall see, and more specifically, the various records that are in our settings. Finally, we shall be looking at the various types of reporting. So we move quickly to a discussion. Why do I call this a discussion? Because the statement has already been alluded to by my senior, the Chief Principal Nursing Officer, Mr. Pisok. If it wasn't charted, it wasn't done. Others say if it is not documented, it is not done. And I would like to see some reactions on the chat box concerning this. This is how it is. If it wasn't charted, it was not done. Is your answer yes or no to this question? If yes, then you substantiate, give a reason. If no, also explain. So we take a minute or two. Let's see the responses. I appreciate those responses coming in so far. Give a comment. Supposing you're confronted and you're told if it wasn't charted, it was not done. If it was not documented, it was not done. Do you agree or do you disagree? If you agree, you have a reason. So you state the reason in the chat box, and I believe our moderator should be able to pick up these comments as they come in. I can already see some comments there. Let's take some 2 minutes, just think through. Let's see, do we have something moving? If this was a physical class, I would have pointed out the participants. Are we together? If it wasn't chatted, it wasn't done. Let's see some responses from us. Do you agree or disagree? Probably the first one is because I see a comment there from Anne Jogo. Very good. We are seeing some responses. We will sample them out and discuss them together. But take time as a nurse and as a colleague and all of us who are in this presentation, respond to this because it means a lot when we understand where we are with regard to documentation of nursing care. Okay, I think we can take these responses that we have so far. Just read through for us. So the question again was, if it wasn't charted, it was not done. It wasn't done. What are our responses?
Yes, Alaska Consolata says yes, I agree. Not charted, no evidence it was done. So it's in agreement.
Keyword there is no evidence.
Mm.
Let's note that keyword. Yes. Another response.
It was done because there was no evidence. So it's not clear.
Do we have any other?
Oh, no, those are the two.
Okay, just reflecting on the two responses that we have.
There are more.
There are more comments.
Yeah.
Let's read through. This is a discussion.
Yes.
And it's very important.
Yeah. And says, yes, I agree. Then Kimutai say yes, because you can't prove that you did it. There are many questions that are coming up even before we start our presenter, that are audio recording part of documentation. Majority are saying yes, I agree, not charted, not done. Stephen says no evidence to show. Mdui agrees, yes, in agreement. Joseph, yes, I agree. It wasn't done because no evidence. Deborah says in agreement. Majority are saying they're in agreement.
Thank you for that observation. I think we can summarize our discussions and say that majority of us agree that if it wasn't charted, it wasn't done. And we have gone ahead to give the reason, because the question down there says how. Somebody would ask how, but the main reason we would say this is true is because there is no evidence, there is no proof of what was done. So if it does not exist in terms of the evidence, then it does not exist even in practice. And this is a principle we need to keep at the back of our minds as we delve into this topic and as we handle documentation of nursing care. Always remember that if it wasn't charted, it wasn't done. So we move on then to our topic, documentation. What do you see in the picture? Again, I would appreciate some responses. Any of those 4 pictures gives you a visual impression of what is going on, and we can continue to receive those comments. But I look at the top left photo, I mean the first 2 photos on top, the top half of this page, you have nurses or healthcare professionals who seem to be documenting, capturing some information from the patient or the client. On the lower end, you have nurses or staff documenting the care. This is going to be our discussion this afternoon, because that which you document, we shall understand where do you get it and how do you go about to write it down. Now we go to our first presentation definition. We would like to understand documentation, and we have a definition of documentation as a written or electronic recording of the activities and outcomes of patient care. Now, written or electronic recording of activities and outcomes of patient care. Documentation is about writing or recording electronically activities and outcomes of patient care. And these activities include, though they're not limited to this, but they include assessment, clinical decisions, any interventions, nursing interventions primarily, and any other, and our evaluations. So again, this takes you back to what we asked. If it wasn't charted, it wasn't done. The evidence of the assessment of the patient, the evidence of any clinical decision that is made, the evidence of the interventions and evaluations made only exists when it is written or electronically recorded. Now, documentation reflects the care provided to the patient. It is not possible for anyone to stand by the patient's bedside and monitor and observe care of the patient round the clock. The only evidence of every activity or intervention around a patient's care is what is documented. Documentation also supports accountability, and it ensures there is communication among healthcare professionals. This is a definition by the Canadian Nurses Association, a very recent one, 2023. This is important to note that as we be looking at the purpose of documentation, some of the aspects here in the definition will feature largely issues to do with accountability and communication among healthcare professionals. So we thought of seeing how did another person define documentation. Just to bring it home, is a detailed account of care provided to a patient. Again, it is about a patient, but then we have to give the evidence of the care that is given to this patient. It talks about what is included in that is the observations, clinical decisions, interventions, and the patient's responses. In both definitions, what is key is that what is being documented is all about the patient. The only thing we put in is the care to the patient. All aspects of patient care is what is documented. Documentation is essential for communication, quality assurance, and legal purposes. So with a clear understanding of what documentation is, then we can look at documentation as an essential component of nursing practice. As professional nurses, documentation is essential in our nursing practice. As a matter of fact, nurses rely on documentation tools to implement the nursing process. The gold standard for nursing care is the nursing process for planning and implementing nursing care. And therefore, for us to do that effectively, we will rely on documentation tools to be able to implement the nursing process. Documentation facilitates a logical sequencing of events. And we have different tools that complement each other and form a system that allows us to have a systematic way of documentation. When we apply the systematic documentation, it presents client care in a logical sequence. And this logical sequence is a reflection of the nursing process, because in documentation, there will be assessment data that is documented. And there will be risk factors and any alterations that are identified with regard to the patient status. There will be nursing diagnosis, whatever is identified, and the plan of care, the interventions, and the evaluation of the same care. So what we are saying is documentation is key in implementation of the nursing process. Actually, at every phase of the nursing process, there is documentation of the care. And therefore, it is important. We need to note that the critical thinking skills, judgment, and evaluation will be communicated clearly through proper documentation. So the question here is, does my documentation achieve this? Does it present a logical sequence of the assessment data, the risk factors, the nursing diagnosis? Does it reflect the nursing process? That's a question you need to ask yourself every time you take time to document care. Then you need to ask yourself whether the documentation achieves that. Why do we document? The purpose of documentation. Why do we document is the question we want to answer in this particular slide. Various reasons why we document. Primarily, it is our professional responsibility as nurses to document care. Having said earlier that at every phase of the nursing process, inherent in the phase is documentation of the care. As a nurse, once you conduct an assessment of the patient, a physical assessment, you will document. Whenever you collect data, you will document that data. So whatever happens during every phase of the nursing process will have to be documented. And therefore, nursing practice within it is documentation as an important aspect of the practice. It becomes our responsibility. It is actually our duty to document the patient's care. Number 2 is accountability. Accountability is about being answerable to the care that we provide. That's in the definition, we mentioned that documentation is giving a detailed account, a record that can be referred to give evidence of the care that has been provided. And therefore, it serves the purpose of providing a reference point with regard to the care that has been provided to the patient. Another primary and important purpose for healthcare documentation is communication. This facilitates communication between healthcare team members, nurses, and other team members, and even between amongst nurses, between shifts, and between interventions. So at whichever level of care, Documentation serves the purpose of ensuring that there is effective communication amongst healthcare members or team members when providing nursing care. What is documented is available for someone else to have a look and to understand where the patient's care is, what is happening regarding the patient, and what needs to happen next. Remember, communication is about sending a message from a sender to a recipient and with appropriate feedback. So documentation enhances that communication. Documentation also serves the purpose for education. Many of us have been through training, and the evidence of care recorded in the patient's records provides resources for learning purposes. It also serves as a data source for research. The care that is documented becomes as a resource for research purposes. And we have literature review of the data that is already documented concerning the patient's care. It also meets the legal and practice standards. In fact, recorded patient care is a legal document. Once the care has been documented, it serves a legal purpose. It can be referenced where need be for legal purposes. And finally, for this section, it also serves as a facilitator of reimbursement. That care that is documented is what institutions, like health financing institutions, will use as evidence of the care that was given to ensure that they have reimbursed the costs of treatment accurately. These are just some of the reasons why we document as professional nurses. Looking at this, then it is very important that each and every one of us, as a professional nurse, always remember that it is your professional responsibility to document first and foremost, but also all the other reasons why we document are very important, and therefore is an important aspect of nursing practice that we need to be keen and alert as we do it. We will look at principles of effective documentation. Whereas the purpose of health and documentation was looking at reasons why we document, principles will focus on how do we ensure that we do have effective documentation. Now, just to mention, requirements for documentation may differ by healthcare facility. For example, how documentation will happen in facility A at a national referral hospital may differ slightly from facility B at another county or sub-county level. It may also differ between settings, even within the same institution. There will be variation in documentation of care when it comes to patients. For example, in our setting at KNH, I would use KNH because this is what we're doing this. A department like Obs and Gyne will have a different set of tools for documentation from a department like orthopedic surgery. So there will be some variations between departments, even within the same facility. There will also be variations on how documentation is done between client populations. You have patients, for example, in our endocrinology ward or clinics, whose documentation tools may differ from patients in a different pediatric ward, for example. Regardless of these differences, whatever documentation of care that is done must reflect the nursing process. So whether we are in different facilities or different departments or handling different client populations, the documentation of care for patients must reflect the nursing process. I need to jog your mind that the nursing process is a systematic approach to planning and providing nursing care to patients. And it is the gold standard for nursing care. And in the recent past, nursing standards has been training all departments in the hospital on mainstreaming the nursing process, making it our standard way of planning and providing care. So documentation is key in should reflect the nursing process. So the principles of effective documentation, we have listed them here If this was a face-to-face session, we would have had a chance to discuss them, but we will continue. And if you have any questions or comments, you can reserve that. Our moderator will give us time to share our inputs. The first one is timeliness. Whatever documentation it is, it should be done in a timely manner. This means interventions, assessments, whatever needs to be documented should happen as soon as the client encounter or the client interaction is completed. For example, when you are performing a procedure or an intervention for a patient, at the end of that procedure, as soon as possible, document on time. This helps protect against forgetting some of the aspects of the care that has been given. It helps you remember what it is that was done and how exactly it was done and what were the outcomes. So the question here would be, should you then document, you have 10 patients, should you document at the end of procedure A for every patient? We said as soon as the client encounter is completed. If you're handling 3-4 patients, you could handle the 3-4 patients, but that should happen, the documentation should happen within the soonest time possible. Let's refrain from waiting to document at the end of the shift. That is not appropriate. So timeliness means just as the client encounter is ended, then you document that which has been done or provided for the patient. Number 2 is completeness. Yes, you ensure that you have documented every aspect of care or intervention that was given. I'll give an example. If a patient was assisted to feed, then documentation should entail that the patient was fed, what the patient was fed on, how much of this the patient was fed on, whether the patient retained or not, and how the patient responded after the feeding. That is a complete account of that interaction. Occasionally, you review records of documentation and you realize we have written or documented patient fed, and it ends there. That is incomplete because it's a whole nursing procedure, assisted feeding, what was fed, how much of it, whether the patient retained, and what was the response of the patient. So that is about completeness. Give all information that is related to what has been done for the patient. Number 3 is legibility. Now this is key. One purpose for documentation or reason for documentation is communication, meaning this information is going to inform someone else, not the person who is documenting. So your legibility is about it being readable. Can someone else read what has been documented? Of course, if this is electronic, that is not a problem. But in most of our settings, we are still handling handwritten documentation. And therefore, we need to be sure that when you're writing patient care, patient interventions, let it be a handwriting that somebody else can see. Legibility is sometimes often affected by how we handle that recording of that intervention. Some of us would want to cancel out what we have recorded, or you write one word and then you write another word on top of that word. Probably you wanted to change what you wrote. It ends up as a word that is not even legible. But the author, you are able to see what you're writing. Remember, you need to communicate, so let it be legible. Let your handwriting be clear. And here also, I talk about a few aspects that make legibility an issue. The spelling mistakes, the small errors that come in because of our influences in terms of mother tongue influence. Be keen, be alert to those influences because it is easy for you to document a different letter instead of what you intended to, and it completely changes the meaning. So ensure that what you have documented is something that someone else can be able to read, not just you. Number 4 is permanence. In your documentation of nursing care, here you write what cannot easily be deleted. That's something that can be a permanent record of the care. That tells us the pen to use is an ink pen, and this should be a permanent ink pen. And in practice, we use blue. There are different color codes for different types of interventions to be documented. For example, if you're documenting patient's allergies, if the patient has any allergies, that is done in red. If you're documenting issues to do with the photograph, I believe we use green. And these are the things we are talking about. But let all this be in a permanent ink that cannot be easily deleted. It's because documentation forms an evidence, a record that can be referenced either currently or many years after. So it needs to be a permanent record. Number 5, it should be factual. So we collect data from patients and we collect a lot of information from the patients. Some of it are facts, some of it are hearsay. So you need to sieve out information and document only the facts that you have collected or have performed in terms of the procedure. 6 is we need to use acceptable terminology. We have terminology that is standard across, used as a standard in the profession, and that is acceptable. But over time, we have also developed language that is not necessarily standard and not acceptable, and we should refrain from use of language that is not standard and not acceptable. I'll give an example of this. And in many settings, you'll find that people will use different terminology for different things. I once had an experience in labor ward many years ago as a student intern. That is the only experience I have in labor ward. And when you're in labor ward and people talk about the first twin, you better be careful what that means. It is not always as plain as it seems, but that is not an acceptable language, especially when it is used in reference to just before the baby is received. So be careful to use acceptable terminology. This also goes together with use of standard abbreviations. In our practice, we have shortened some of our terminology to non-standard abbreviations. If I'm writing the blood pressure, BP is a standard term, abbreviation, so that is acceptable. But if you're writing treatment, RX has never been a standard term to use, neither has CT, and any other that you have been using. References for standard abbreviations are available. Only use abbreviations that are standard or terminology that is standard in terms of communicating. It ensures that we communicate about effectively. Accuracy, when documenting, ensure that what is recorded or documented is accurate. For instance, if you're recording the temperature, then you have to give the appropriate unit of measurement, and any slight change in the number that makes it inaccurate. For example, if you needed to write temperature 37.5 and you write it 37.9, that makes a big difference. So let it be accurate. In terms of the measurements that you take, ensure that they are accurate and you document them accurately. Remember, once you document, it is available for other people to use and take appropriate action, appropriate interventions. If it is inaccurate, it is going to set off a channel of inappropriate intervention. So we have to be very accurate in our documentation. Correct spelling and grammar. I think I mentioned this also under legibility, but I need to emphasize it here again. Be careful and keen on the spelling and the grammar. Sometimes meaning changes depending on how we spell the words, and this is something you just need to be alert and aware of. Ensure there is sequencing or organization of the events. There should be a flow of events. For example, if you are documenting here in a sheet, what comes first, what was done first should precede what was done much later. Occasionally you will meet that somebody has documented a procedure and then they remember that there was another procedure that was done prior to that and they document it after. If someone is looking at this record, then it raises questions. Was this procedure actually done? How comes this came after the other? And most of the time, You fall victim of a problem with sequencing when you actually document in advance, which is one of the things I would say, never document in advance. There are some don'ts about documentation. Never document in advance, because sometimes in ignorance, you decide to determine and say, I have set up my procedure trolley. I am going to conduct this procedure, probably to perform a wound care. But for some reason, things change, and that doesn't happen as you intended. If you had documented in advance, then there's a problem with that documentation. Therefore, ensure that you document events as they happen. What came first should be documented first before what followed. Appropriateness. In documenting, use language that is appropriate, and also document appropriately. Conciseness, this is try to be brief. Again, during data collection, there's a lot of information, but be brief and be specific, straight on point, what we call be on point, to avoid being wordy. Legal prudence, what is documented should be legally correct. Look at what you have documented, because we said documentation serves the purpose of, it's a legal document that can be referenced to much later. If someone is looking at it, they should see a professional nurse performing a professional role without raising questions whether this is a professional nurse who did this role. Finally, confidentiality. I say finally for the purpose of the presentation. There are many other principles of effective documentation, but these are the key. Confidentiality. Maintain confidentiality. Once we document, it is upon us to ensure that the content of what you have documented is only available for purposes of official use by those authorized to use for care provision, and not just to anybody. And therefore, I wish to say that this apply in every encounter that we have to document. So what you need to do is to ensure that at any point in time as you document, look at what you have documented. Does it meet this list of principles we have looked at? Have you ensure that you document on time, that it is complete, any aspect of the care is there, it is legible, it is permanent, you are documenting facts and not hearsay, you're using acceptable terminology, ensure there is accuracy, especially when it comes to units of measurement and values that are measured during care, use correct spelling and grammar, sequence appropriately, ensure that you're documenting appropriately, concise, be specific to the point, like all these things that we have talked about. So if you apply this, then at the end of the day, we have what we call effective documentation. Now, we have various methods of documentation. I will not put much emphasis on the methods because many a times we rarely stick to just one method. But I'll mention briefly in passing each one of these methods. Narrative charting. Here you write a story. I doubt anyone does this anymore. Most of our documentation now is well structured, but narrative charting referred to where you write as the patient narrates or explains, mostly used in history taking, but we're not currently using this as much. Source-oriented charting, where different members of the healthcare team will document in one document. So the source is the different people who are documenting, but you're all sharing one document. Again, this doesn't happen many times, but in some of our documents in the patient's medical record, you may find one record where other providers will document. For example, the medical progress notes. Usually the medical team, doctors will document, and any other multidisciplinary team that is providing care to this patient will also document the same. We also have problem-oriented charting or documentation. The focus in this is you only focus on what is the patient's problem. And that is what you document, and that is what you plan care around and about. Problem intervention evaluation charting is an enhanced form of the problem. Once you document the problem, then you go ahead also to document the intervention, then the evaluation thereafter. Focus charting will highlight the client's concerns, if there are any, and also sometimes the strengths, not just concerns, because you want somebody else to be able to build on that and be able to provide care. Charting by exception. In this one, the focus is what is abnormal, and there are times you do this objectively, because not every time should you document comprehensively. There's a time for comprehensive documentation, but there's also a time you document by exception. So again, many of these will rarely apply in isolation. Computerized documentation is the way to go. We are heading there. And here is where we look forward to where we can document our nursing care plan with the computer. And the rest, I know I've not talked about management, but it is also a method. Now, types of documentation records. There are many. These are basically the tools that we use to document. A client's medical record will contain documents, different documents. And when I say a medical record, I'm referring to what we commonly call as the patient's file, especially in our setting. So that whole patient file will have different tools inside that will be used. So the type of document that constitutes the medical record will be determined by the healthcare facility. What goes into that medical record depends on the healthcare facility. Now, within our setting in this institution, we have different tools that will be found in our medical record, but key for nursing. The question here is, what are some of the medical record documents in your institution? I would want to see in our chat boxes, could we throw in something? Tools that we use to document. This should take a second to write, just one. Yes, very good. Observation charts, Cardex. Mugi, you can read for us.
Sure. Perfect. Gertrude Chesang says observation charts and Cardex. Okay. Mother says nursing Cardex, this photograph, nursing care plans, thank you. Daily activity register. Monitoring Paco charts, injury chart. Thank you, members. We appreciate that you are online with us. Input output charts. For risk assessment forms. Discharge summary, treatment sheets. Incidence reports. SSI prevention bundles checklist. Random blood sugars and fasting blood sugars charts. Feeding charts. Permanent register and immunization tally sheets. There are many.
There are many. Thank you. So again, just to echo that what will constitute a medical record will be all of this or some of this as per the institution policy used to document care. I just didn't hear our vital signs charts. Did anyone mention vital signs? Oh yes, observation charts for vital signs. Good, good. And just to note, the other day on our forums was a discussion on the right name for the input output chart. And we learned that it is intake and output chart. So those are the things that we are looking at. Now that brings me to the end of the first session of this presentation on documentation. We have looked at our first 3 objectives. If you have questions, just hold them so that we can handle them at the end in the interest of time, so that I can move on to the second part of it. Remember, the title was documentation and reporting. So then we can move to reporting. It starts with a question. We are now on reporting. All records are reports, but not all reports are records. True or false? Your answer quickly in the chat box. We just moved from the documentation tools. Yes, we are now on reporting. And the question there is all records are reports, but not all reports are records. So you say true, you say whether it's true or false, but also explain your answer briefly. Why your answer is yes, true or false. If we have 3-4 responses, we can look at those ones maybe.
Sure. Gertrude, Mary Morel, Brian, Zachariah all said true, however, they have not validated their data. They have not given the reasons as to why they think it is true.
Okay, anyone who has given reason? No, we are still writing the reasons.
Yeah, sure.
Okay, I see most of us agree that all records are reports, but not all reports are records. Okay, Lucy says something.
Lucy Koya, thank you. She says true, people forget to record.
Okay,
Brian Oche has added that reports are not either written or electronically recorded.
so is that true or false? Brian will give us an answer. Onesimus has something there.
Sure. Onesimus says, yes, it is true because some reports may be verbal.
Okay, so we seem to understand this. We will clarify. All records are reports, but not all reports are records. The answer here is true. For us to understand why true, we need to go through this presentation and then we can be able to explain our answer. So, what is a report? It's an oral, written, or computer-based communication that is intended to convey information to others. It's basically a communication. It's a communication of which nature? It is either oral, it could be written, or computer generated. What is the purpose of this communication? To convey information to others. And in our context, we are conveying information between healthcare providers, between nurses, between team members. Now it summarizes, a report will summarize current clinical information, which will facilitate clinical decision-making and ensure continuity of care. So even as we consider a report, whether we are giving it verbally or writing it down, we must ensure that whatever information we give should enable someone else to make a clinical decision, should also ensure someone else to ensure they are able to continue with the care, and it should be concise. So that is a report. Remember, we said it is a communication, verbal, oral, written, or computer-based, but intended to convey information to others. Then, if that is a report, the noun, what is reporting? I call this the verb, the act of reporting. It is now giving that verbal or written communication of data regarding the client's health status, needs, outcomes, and responses. So basically, when you have a communication in those 3 forms, and then you go ahead to give that communication, you have actually done reporting. It is based on the nursing process, standards of care, and legal and ethical principles. The nursing process is involved for good reasons. In documentation, we said we implement the nursing process through documentation. Now we are talking about reporting for continuity of care. All those assessments and data and any other interventions done and the evaluation is communicated through reporting. So again, reporting actually facilitates the nursing process, implementation of it. So there was a report and there's a record. Those are 2 words. A record is a written or computer-based communication. So it is possible to ask yourself, then what is the difference between a report and a record? That one I need answers on the chat box. We say the report is a communication. We are also saying a record is a communication. What is the difference? Quick answers. What is the difference between a report and a record? Any answers so far? As the answers come in, I see some observations that have been made concerning the CPD code. We will respond to that. So just be patient with us, we shall respond. But for now, I need to know whether we are together. The difference between a report and a record. Quickly, yes?
Martha Macharia says a report can be verbal or written. So Martha, what about a record? Okay. Martha says the record is
On paper.
Is on paper.
Okay, so she says a report can be verbal or written, but a record is on paper, meaning it is written. Okay, someone else is saying the same thing, just using different words. Steve?
Yeah.
Daisy?
Daisy, a report can be verbal when a record has to be written.
Very good. So we have said a report has an alternative, it can be verbal or written, but a record must be written. That takes us back to the question we asked ourselves. All records are reports, because all records are written, but not all reports are records, because not all reports are not. Let me go over that again. All records are reports, because we have said a record must be written. But not all reports are records, because reports can be verbal. That is the difference. That is the explanation for that question. So we move on. Now we know the difference. In order to communicate in an efficient and well-organized manner during the report, in a report, you need to consider the following as a nurse. Before reporting, consider what needs to be said, why it needs to be said, how it should be said, and what is the expected outcome. After you say this, so what? Remember, you're giving probably a verbal report. Then you need to know that the report I need to give should include this aspect. And how do I even say this report? And what do I expect? If I'm giving a report, the patient input and output, I'm reporting an input and output that has a negative balance. What am I expecting from the person who is receiving this report? That they should take up some action, probably to correct or seek to understand why there is a difference. So always consider your report. And I want to urge all our nurses on board in this presentation. As you sit to document care, especially in the CADEX, which is what we use most of the time to hand over, all the time. Consider what needs to be said. Not everything needs to be said, because you're communicating for someone else to be able to make a clinical decision and to continue with care. So especially just communicate, document, or report what needs to be said, why you need to say that, and how you say it, and what is expected. And during our training, during the mainstreaming nursing process training, we went through how handover should happen, and in reference to our work instruction in KNH on clinical handing over. So that is something we considered very carefully. Remember, listening is also a critical element of reporting, because it is about communication, isn't it? A report is a communication, as we have agreed, whether verbal or written. And therefore, someone needs to listen or to be able to understand what you are saying and take appropriate action. Reporting is important. How? What is the importance? One, it communicates specific information to others. So it's a channel of communication. Or it facilitates clinical decision making by summarizing current clinical information. Finally, it ensures continuity of care. Almost a repetition of what we have already discussed, but these three things are very key. Whenever you are preparing to give a report, ensure that you are able to communicate specific information to other people. Ensure that whatever information you give can help someone make a decision. When we communicate, for example, in our verbal reports during handover, we are saying this patient is scheduled for a biopsy, for instance. You want the next person receiving this patient, one, to make a clinical, to be informed, but also to make a clinical decision. What do they need to do? Probably ensure that the patient is prepared for the procedure, or the preparation has been made and the necessary arrangements have been done. And you ensure that that particular care is continued, that the procedure can be concluded and done. We have different types of reports. We have different types of reports, and I sampled a few that are more common in our practice settings. These few will form a basis for our conversation this afternoon, after which we shall allow time for questions. They are very familiar, but they are very key reports. One is a summary report. Summary reports. We have reports we call walking rounds, telephone reports and orders, and incident reports. In fact, in one of our answers in the previous discussion, I had somebody list one of the tools of documentation as an incident report. Now we look at that in detail. Summary reports or change of shift reports. The summary reports give, these are reports given to all nurses on the next shift. By the way, at KNH, we have a work instruction on handing over, and it outlines the procedure for handover at the end of the shift. But we'll summarize here some of the things that are in that work instruction. So summary reports will typically occur at the end of the shift. And in our setting, most shifts we have two main shifts. There are others, but we have two main. A day shift. So at the end of that shift, it is expected that the nurse will hand over. And after a night shift, again, there will be a handover. But if there's a morning and afternoon, that can also allow for handover for the purpose of continuity of care. We say they may be written or given orally. There's what is written and there's what is given orally. So be careful to see which needs to be done. The main purpose is to disseminate information between shifts so that there is continuity of care. Nursing care is round the clock. There should be no reason for any breakdown in care. Again, it gives the incoming team a quick summary of the care that is to be given. It's a very important report. So it is expected, I think in our handing over work instruction, we say that all team members in the incoming shift should be present. And then the outgoing shift, only one person should be exempted to be available at the nurse's station to respond to any emergencies that might be happening. And any other nurse who might be involved in a procedure that has drawn their attention. But the rest of the team on night duty should also be in the handing over report, because we want to ensure there is continuity of care. What should it include? Again, I say it should just include the information that will enable somebody, one, understand the patient's needs, and be able to plan the care to ensure there is continuity of care. So identifying information for each client in KNH, this refers to the patient's 3 names and the patient's unique medical identification number. That is very important. The patient's 3 names is key. That is also in our hospital guidelines in terms of patient identification. It's a safety issue. So anytime we are handing over, that should be in that report. The primary medical diagnosis, the nursing diagnosis, and priority problems. Patients may have very many problems or needs, but what are the priorities? That is something that needs to come out during our handing over. identification of any client risk problems. There are problems which the client has not developed. You have a patient at risk of developing, for example, clots after surgery, following surgery. So to prevent this, these patients are probably supposed to be on some anticoagulants. And this needs to be anticipated and the care planned upfront. These patients are supposed to be mobilized postoperatively in a timely manner. Recent changes in the condition or treatment, this should be reported. Effective interventions, what has worked, and for treatments of priority problems, it's good to report what has worked. Any interventions given and the patient's response is positive should be communicated. Progress towards expected outcome. The patient is with us and we are saying patient A, B, C. This is day 55. Give progress towards expected outcome based on the patient's condition. Adjustments in the plan of care. Any changes in the plan of care needs to be reported, and any physical or psychosocial problems that exist. For newly admitted clients, some details need to be given, a little more detail. And for our setting, during handover, these patients, we should give a comprehensive history, because the person who did the initial assessment is the most suitable person to speak about the patient with regard to all aspects in terms of history taking. So the reason, the age, reason for admission, the diagnosis, the general condition, all diagnostic tests done. If planned, date of surgery, therapies, the last 24 hours, the care that has been there, and the plan going forward. Any significant information about the client support people. This comes from the patient's medical history, comprehensive history. So that should be included for new clients. For clients who are transferred or discharged from the unit, priorities of care need to be highlighted. You're transferring a patient from ward A to ward B. There are priorities of care, and the new team may not be alert to this. So you need to highlight this as you transfer the patient and as you hand over this patient in this summary report. Provide exact information, again, be concise. Avoid elaborating on the background data or routine care. Usually background information is very sweet to listen to, but remember, handing over report is usually timed. It should happen within 1 hour at the beginning of the shift because of the number of patients that we have. So if you are reporting and receiving report between 7:30 and 8:30, then you know that you don't have all the time to tell everything about the patient, even though you have collected that data. Client or family complaints should also be reported, but always do this at the end of that client's report, because it always generates a lot of conversations and it can be time consuming. Why are we reporting client or family complaints? They need to be addressed and resolved within the recommended timeframes. That's important. They should not be ignored. So that is about summary reports. We quickly move to what we call working rounds. So you realize summary reports, I call them handing over because that is our local context. Thank you. Now the working rounds are not very common, but typically it's a multidisciplinary round where team members visit the patient's bedside and discuss the patient's progress with each other and with the patient. So this will not be a routine round, but you have clients for one reason or the other. You need to discuss their nutritional status, you need to discuss their rehabilitation, how it's going, or any other aspect of care. So you come together, a multidisciplinary team, and you go through this. Now they are more time consuming, but usually mostly used for teaching purposes, but also are important when you really need to make a decision, joint decisions by team members. Telephone reports, very common. In a shift, there is no nurse who can miss to receive a telephone report. Reports are about the client all the time, whether it is about transfers, referrals, or just client information coming from the various service points. It could be from the lab, from the X-ray department, issues with the client, problems being solved, or communicating the change in the client's condition, whether to the family or to the physician. All this we engage in this. Very important is to demonstrate phone courtesy and professionalism. It is not so much the content, but the method. It matters first. And I want to quickly mention an example. Many times you would lift the handset and call a certain department or ward or unit. The receiver would quickly say, word 4X, for example, or 4X, yes, let me use X. We don't have that in our setting, but imagine you're saying hello and somebody says 4X. It leaves you wondering, who is 4X? The person receiving the call, the unit. In fact, you think you have called the wrong destination. Phone courtesy is very, very key. Even the tone matters because this is not a face-to-face conversation. So the tone is the only thing that the person on the other hand has to judge whether this is received well or not. Again, phone calls should be documented. So how do you handle this so that there's courtesy and there's professionalism in your phone? You need to organize the information to be reported or to be received. Before you lift the handset to receive a phone call, as a professional nurse, be ready to document something because we have just said in the preceding slide that they should also be documented. So we always have a notebook somewhere to write what it is that is going to be communicated. And if you are the one who is making the call, now I'm referring to the one when initiating a telephone call, organize the information before you start the story. If you have information concerning lab results, they should be available so that you can inform the person you are communicating to. Quickly review your notes, especially your assessment data, so that you're talking about the patient and you're giving accurate information. Avoid interruptions as much as possible. If you are receiving a telephone report, a call, again, I said be ready to document and capture the date and time. Who is the person giving you information or reporting? What information they are reporting? And you will sign. And I want to use an example. Many times we initiate calls. We call, for example, a service provider, a different department, blood transfusion unit, for instance, you call, and you find out whether you have blood available for patient ABC. And the person gives you information. But by the time you're handing over, you have no information of who gave you the information, the details of what information was given, very specific. Is it that the patient, there is no blood available? There has not been donation from the relative side. What is the actual information that is given? We need to capture that. So most organizations have an SOP on how to respond to telephone conversations. Can I see in the chat box, but that will take time. Allow me prescribe how we should respond on telephone in the interest of time. Whenever you lift up that handset, you should be first of all be able to show courtesy. And the first words to show courtesy is to say thank you for calling this word. Thank you for calling word 4X. Remember the example I gave. The person who is calling will feel welcomed to proceed with the conversation. So I would like us as an institution to adopt and say, when you lift up that handset, show courtesy by just saying thank you for calling this word. Name your ward or your unit. Thank you for calling labor ward. Thank you for calling A&E. Thank you for calling 5th floor, whichever office it is. Then go ahead to identify yourself. Who is this receiving the call? So thank you for calling Nursing Standards. This is Ruth Nyansikera speaking. How may I help you? That is a very courteous reception. And anyone will be warm and willing to give information. Put that in your context wherever you are and let's adopt this and it will make a big difference in how we communicate. So there's an example here of what is being reported over a telephone conversation and it is captured that when you document now after receiving the call May 13th, 2025 at 11:05 a.m. KJ Biko, the lab technician, reported by telephone that Mrs. Amani Bibi's HB is 3.4, grams per deciliter. And you who is writing this report, you document, my name is Abu, as written there. So this is an example of what we are saying. But remember my remarks in terms of courtesy, you don't document courtesy, but actually when you're receiving, be courteous enough to say thank you for calling this word and identify yourself. Now, how does the receiver ensure accuracy if in doubt about information? Remember telephone calls, sometimes you may not have, you want to be sure that what you have had is accurate. How do you ensure accuracy? You ask the caller, you paraphrase, read back what you have captured in your record to the person. So you go back and say, I heard you say the HB for KJ vehicle is 3.4 grams per deciliter. The person should respond affirmatively or not. Then you'll be sure that that was accurate. Remember, we talked about accuracy in documentation. You must capture it very accurately. There's a lot about giving a telephone report, but this is information that we can actually read on our own. I want to save some time for us to be able to have a conversation and discussion. I see that what is here, I have already mentioned it. Yeah, I have mentioned all this. The only thing I have not mentioned is institutions. When I say most agencies, we mean institutions have policies on telephone orders. Sometimes prescriptions are done on telephone, but most of these have guidelines by the hospital or the institution on ownership. That if a prescriber is giving communication or reports on telephone, they need to own some of those orders or instructions within 24 hours mostly, but I would refer you to as per your hospital policy. Okay. Now we have telephone orders specifically. Let's just quickly look at telephone orders because we have reports we receive generally, but we have telephone orders which are usually prescriptions. They should also be documented. Write down the orders and repeat it back to the physician to ensure accuracy. Question any order that is ambiguous. If it is unusual or contraindicated for this client, it's an order, yes, but raise the question, say, is this okay with this? Because you understand the pathophysiology of the patient or the condition. Transcribe, that means write the order onto the physician's order sheet. This is done by the fellow physicians and indicate a verbal order. Finally, this order must be countersigned to become part of the permanent record. So the callers must avail themselves to countersign these instructions. Don't accept orders from prescribers you do not know. If you cannot identify Dr. So-and-so on phone, how do you know that that is actually Dr. So-and-so giving these instructions? Or this is, yeah, so be careful. If they're not known to me or anybody in the unit, then this is not okay to take instructions from them. The rest are things we can read. I say read the order back to the prescriber at the end and use words instead of abbreviations. Again, refer to the hospital protocol. Hospitals have protocols on how to handle this. A final report that is key and we interact with a lot of times is the incident report. This only documents unusual occurrences or accidents. For example, it is not usual for patients to fight. That's not what is expected. So that is something to be recorded. It is not usual for a patient to fall. It is not what is expected. It is not usual for probably, how about staff? Even staff. What? If you have all the examples, yeah, I would have had time. If you had time, we would go through the examples. But there are things you find unusual. That is what, and sometimes there are also accidents. Accidents do happen. Those should be reported. So most facilities will have for documents prepared, tools for reporting different incidences. And this is where we mentioned that at KNH we have a protocol on escalation of reportable events. Familiarize yourselves with this protocol. It lists the types of events that need to be reported. Reporting is also, in the local context, is also a way of escalating. We have reasons we escalate, but more important, it is what should be in an incident report. Whatever incident you're talking about, the format will vary, the tools will vary, but there are things that should be there. For any incident, the date, the time, and the place should be documented. 3 things: date, time, and place. Persons involved and witnesses should be in that document. What happened? Mostly use direct speech. You are reporting what happened. It is mostly what you observe or at the time you encountered it, whether you are called. Sometimes if a patient calls, you'll be called by another patient and you find the patient on the floor. So you'll be documenting from that point what you have observed. So you record exact details. Consider the time sequence. It is important what happened first and what happened last. Record your actions, and this is where we have provided for a provision in most tools for your actions to provide care in the incident or the accident. If it required care for this patient, record the care that has been provided and your assessment of the patient's injuries and client and the interventions that have been given. This needs to be so the supervisor needs to be notified, and whether by telephone or other means, that needs to be communicated. Your opinions, judgments, conclusions, assumptions, suggestions should not be part of an incident report. Here you just capture events as they happened and you leave it at that. So forward incident reports to designated persons, depending on your facility policy. And I said for KNH, let us familiarize ourselves with the escalation policy it's in place. Now, incidents will happen, and many times we shall document. And as we said, we forward this, probably we forward these documents to the supervisor, and we forget. What happens many years later? Because they have a way of coming back. How would you ensure accurate recall of an incident several years later? For example, I worked in medicine department, 2003 to 2006. There were patients who were missing, patients who absconded. I wrote some documents. How do I recall such a patient 10 years later? Anyone who knows the answer to this question? That is the last question, and that is the end of the presentation. How do you ensure that you can recall an incident several years later? The chat box is free. After this, we will take your questions and comments.
Wow. Thank you so much, Ruth, for such a beautiful presentation and to the point. Documentation is usually a very huge topic, and compressing it within 1 hour, 30 minutes, I think you have done a very awesome job. Cheers to our participants. We have clocked 578 participants. Cheers, thank you so much. And thank you so much for the very interactive session we have had via chat box. I think this was the most, this is where you have really participated most. And thank you so much for the many love emojis and thumbs up that you continue receiving. We love you back as a department. Now, Ruth, a question. Somebody is asking, who is anonymous. Do we have a minimum written record per patient shift, e.g. half a page or a full page? What are your thoughts on that?
I take one by one.
Yes.
Okay. Thank you, anonymous attendee, for being attentive and for your observation, whether we have a minimum record per patient per shift. I have not come across this in the literature because documentation is about a patient and there are no standard patients. Patient A will require care and interventions that can take half a page for you to document. Patient B may require more interventions and more assessment and whatever else it is you're documenting, and will take more time. So we will not be able to prescribe and say half a page or full page. We only say apply the principles of documentation. Be concise. That helps you to manage the space. Thank you.
Wow. Thank you so much for that feedback. Ed Frank, majority are asking for these notes or for this presentation. What would you tell us?
Thank you. Okay. I think these notes will be uploaded in the KNH website, and they can be able to access them from there.
Okay, thank you so much. If they be uploaded, I think we can get them from there. Now, presenters, we have all understood the reasons as to why we document. Then why don't we document? So now that you have quite an experience in clinicals, why don't we document and how can we overcome this barrier?
Thank you, Mugi, for that question. I think that's a good question for the participants. Participants in the house, it is us who sometimes do not document. What are the barriers to documentation in your own experience? Let's allow them to give us one or two.
Sure.
Feel free to use the chat box.
And maybe as we respond, let's see how can we try to balance that thoroughness in writing the report and its efficiency, especially in our very fast-paced environment where time is limited. How can we overcome that barrier? Write it down.
Any observations so far on some of the barriers to documentation, barriers to effective documentation? Yeah, I can, in the interest of time, I can respond to that. From experience and from our interactions with our colleagues on a day-to-day basis, most of the time nurses will say, we don't have enough time. Why don't we have enough time? You have a 14-hour shift. That's a long time. And during every shift, there should be documentation. So first and foremost, they will cite large number of patients, the nurse-patient ratio. And this is a reality. It is true that in any given shift, you hardly have what we call the ideal nurse-patient ratio. Hardly would you have that. And that is the reality. So then we cannot say we will not document effectively. What we can do is look at how do we overcome this issue of a high nurse-patient ratio. One is to prioritize care. And that is where we come in with patient categorization, as we taught it and as we continue to teach it during the mentorship phase of the nursing process training. When we do patient categorization, then we are able to prioritize care. And even as we document, we are able to consider, what should I document about patient A? Yes, patient A, the patient linen was changed. For patient A, who is a category C patient, that is good. For patient B, who is a category A, that is key, not just good, key. So you also should prioritize in terms of the actual care and therefore the documentation of care. So prioritization of patients will really help us know where we focus our attention when it comes to providing care and the relevant documentation of the same. That is one way to address the nurse-patient ratio. Number two, yes, we have the SBAR communication. Mugi, you want to talk about that?
No, somebody is asking, does the SBAR, use of SBAR has any role in enhancing the thoroughness of the report to increase its efficiency, especially in a time-limited setting?
Thank you for that answer. That's another answer to the question that we say barriers to documentation. When you want to organize your information and communicate effectively, the SBAR approach will really help you. Where you specifically go to your situation, quickly give that documentation of your situation, the background information that is relevant to what you are documenting, the SBAR. Okay, I forgot the name. Yes, that approach will really help. The assessment, so I remember the assessment, and therefore your recommendations. If you use the structured approach of SBAR communication, you will be able to be precise, and that will save you time, and you can be able to do this for even many patients. Thank you for that input.
Wow, thank you for the next answer. Now, there's a very good question here. We have talked about records. Now, an audience is asking, is audio part of documentation? Mr. Koisok, the host, would you answer this one?
Yeah, thank you, Mugi. So this question I saw, I think it was among the first questions. Someone asked whether audio is part of documentation, and the answer is yes, but it forms a record in the documentation. And so you find most people don't practice using audio, but people who do mostly, they do it using, especially in digital documentation or documents like Word or PDF. And the procedure they use usually is they embed the audio file directly within the document, or maybe they use a link to external audio files. And just to it's a bit of clarification, to embed is the action of including something within another thing. However, as you do this, there are some considerations you have to put in place. One is about patient confidentiality. How will you ensure that you don't share or it doesn't leak? Number two is data safety and security. It's about access and storage. And so which measures are you putting in place to prevent unauthorized access or misuse of data? Number three is issues of consent. Before you do this, you make sure the patient knows actually that you're doing an audio and not a physical paper documentation. Number four is about legal compliance. So as you do the audio documentation, one, you should align within the relevant Kenyan laws. And when I talk about the Kenyan laws is, number one is Kenya Information and Communication Act 2015 and the Kenya Data Protection Act 2019. So those are those are the responses concerning audio documentation.
Wow, thank you so much, Mr. Koisok. Madam Ruth, thank you so much for emphasizing that we should always demonstrate phone courtesy. You shared some of the experiences that you have had. Mr. Richard, have you ever had a funny response over the call? You call, then somebody says, hi. Is hi an official? Does it demonstrate courtesy?
Of course, I is not an official. An official, it looks like more of a social, and with further description is like people of the same peer or the same age, and not a professional way of communication.
Sure. Thank you so much. And Ruth has also emphasized the use of international accepted abbreviation. Ruth, have you come across funny or most scaring abbreviations you have seen? Personally, I saw D times 1, and that meant diapers times 1. Any crazy one that you have had?
Let me just jog my mind. Not really crazy, but I didn't understand what it meant in the recent past. If I remember it, I'll tell you. I was in one of the units and I had to ask, what does this mean?
Must have been cut A. There is use.
Oh, yes.
We are really using cut A, cut B, cut C. What are your thoughts on the same?
So again, I think the reason we are quickly writing cut A, and this, I don't want to put it as a standard way, but here we are referring to patient categorization. So the idea, the right way is category A, category B, category C. Let us refrain from using cut A because that is nowhere in documentation. And if we prioritize care, then we'll be able to have adequate time. If we document care as soon as it happens, remember the principles of documentation, timeliness. The reason you have to do cut A is because you started a shift at 5:30 p.m. and you decide to document all the care at 6 a.m. in the morning. Surely that will not be adequate time for you to both give the care due at that time and document. But if at the end of the conclusion of some procedures or interventions early in the night shift, you documented the care, then you'll have just enough time to write category A. Thank you.
Wow, thank you so much. Mary Muriu, she's asking, is it important to ensure no blank spaces between report? Ruth.
Very important point there. Thank you, Mary, for that input. So in the nursing codex, for example, you would write a statement and there should be no blank space. But most often what you will see is there should be no blank space because anything can be filled in. But I wanted to also comment on when you write a sentence and your documentation has not occupied the full sentence, what happens to the space at the end? If you observe this record I have put here, I'm trying to just show the record. Which record I've put here as an example of an entry in the codex. It shows that the patient's HB is 3.4 grams per deciliter, full stop. But there's a whole space between that particular point and the margin of the codex. You draw a straight line to the end of the codex, and then you can ownership. I also forgot to mention that should you want to erase something, kindly do not use correction fluid or what we call whiteout. The standard for documentation is cancel with a straight line. Then on that deletion, insert your new entry, but also sign against what you have canceled with a straight line. I hope that is very clear. No use of correction fluid. What you have corrected should still be visible to the next person. Nothing should be concealed. Thank you.
Wow, thank you so much. We really appreciate those responses. Questions appears to be many, but for the interest of time, we need to wind up. But as we wind up, before we give our CPT coordinator time to say a word, Mr. Koisok, something to top up?
Yeah, I think it's just follow up to what Ruth has mentioned, correction fluid. Correction fluid, most people, they use the term whiteout. So if you hear correction fluid, we are not talking about anything different, but it's the whiteout which people use. So you find most people do use whiteout, and then they write whatever they were supposed to correct on top of the whiteout. It's not allowed legally and professionally.
Wow, thank you so much. Hey, there's a burning question here that we must respond to this one. Is it, Onesimus Kipngeno, is it legal to write a report on behalf of someone else? For example, your seniors. Very nice question.
That is clearly a don't. It is not legal to write a report on behalf of, if we are talking about a patient report on behalf of someone else, because you are recording what you have either provided care or observed or assessed. So if someone did the assessment or the intervention, they have done a procedure, wound care, for example, and you are required to document. You did not assess the wound, so you have no information about the status of the wound. You do not know what was used to perform that procedure. You do not know what recommendations you have for that particular dressing or wound care procedure. So that in terms of patient care, document what you have done for yourself. Thank you.
Thank you so much, Ruth. And thank you so much, Frank and Team Nursing Standard. Today, majority of the nurses are not raising issues concerning CPD. However, there are still few nurses who are not getting these CPDs. However, we have our colleagues, clinical officers, they're saying that they do not get this CPD. Frank?
Yes. Yeah, I think to respond to Morito on CPD, Morito is a clinical officer. These webinars, we have every, profession getting points through their regulating body, like Clinical Officers Council. Nurses will get through, NCK. So I would advise Morito to get in touch with the Clinical Officers Council, where you can be able to get CPD points. Then number two, there are a few questions. Somebody is asking that, how can I get CPD? I believe this is a nurse, and this particular presentation is CPD accredited. And what you need to do is after you get a CPD code, which will be sent to you shortly. You have the steps to claim the CPT points also attached. You follow those steps, and then you can be able to redeem your token. Number two, just a general comment. We have, for those who are complaining that they don't get CPT points, we have a CPT eligibility guideline for getting CPT, which requires you to participate for 30 minutes and above so that you can be able to qualify for CPT. So make sure that every time we have a presentation, you are participating for 30 minutes and above, and you'll be able to get your CPT points. Then it's also important to note that when the code is sent to you, it expires after 48 hours. That is basically 2 days. So you don't claim after 48 hours. Then in the event that you have challenges in claiming CPT points, you can get in touch with the email cpdnursing@knh@gmail.com or call KNH extension 43975. You'll get clarification on your CPT. Thank you.
Oh, thank you so much, Frank. So you mean even if you're outside KNH, you can always call the KNH and request to be connected to nursing standard. There you'll be assisted. If you're within Frank, I'm sure they can always come to our department.
Yeah,
At
6th floor.
6th floor,
Yeah.
you will be assisted. I think we have done a good job. Thank you to the presenter and thank you for the whole team. Our boss, I think you need to appreciate us and also appreciate our colleagues who are outside. For motivation.
Thank you, Elizabeth. I wish you could see me. I was smiling when she was saying that. So we've come to the end of our presentation. But before I appreciate everyone, allow me, I think there's a question which has come separately for people who have joined late and how they're going to get the presentation. Kindly visit our website, KNH, UN webinar, webinars.knh.or.ke. That is where the presentation will be uploaded. And you can, so when you visit there, you will find it already uploaded, maybe after some hours from now. So with that, allow me to say thank you. But before I say thank you, there's one of us, you find we are somewhere presenting, but there's somebody seated in the office who does the background, somebody in the back office who does a lot for us to move. She's called Sally Kaino. We appreciate her, and thank you so much, Sally, for the good work. And allow me also to appreciate Ruth, Elizabeth, and Frank for the teamwork. I also appreciate the medical research department for facilitating this webinar. And at the same time, allow me to appreciate all those who participated in this presentation. We are planning for more series. We'll communicate like maybe next week for another one. Kindly tune so that we have a proper discussion concerning our practice and safety of our patients and outcome of our patients. I also appreciate the management of the hospital. I think providing us with the resources we are using to make sure you guys receive this presentation in a clear way and having time to have this discussion. Thank you so much. I wish you a good day. Be blessed.
Wow, thank you so much, boss. And from our end, we really appreciate you for your participation and for keeping up to this time. And as a department, we all say happy International Nurses Week. Enjoy yourself and beautiful evening. See you.